Hello, this is a video made to demonstrate the strategy for the resection of a large lesion located at the mid-upper rectum and the distal sigmoid colon. This is a large LST with a JNet 2A and 2B pattern. There are no signs of advanced malignancy of submucosal invasion. The patient has been positioned in such a way that the gravity is pulled against the lesion, so in this case at the left side. The first step is to create an anal incision. For this part we use a flash knife, bolt type 1.5 millimeters, and the standard setting for this is endocut 2-3-3 with the value 3 setting. And we do a partial dissection of the submucosal space, either in forced coagulation or in spray coagulation. Once we have done the distal anal incision, then we proceed with oral incision. And this is very important in order to have an end to the tunnel which will follow. For this procedure I use a gastroscope. This is the 1500 by Olympus and an ST hood by Fuji. My favorite knife is a flash knife, bolt type 1.5 millimeters. So here we do the oral incision, and in this part of the procedure we are tangential to the muscle, to the wall, so undersaline immersion provides a safety measure for this part. Once we have completed with oral and anal incision, we start the tunneling, and for tunneling I like to use spray coagulation effect 3 with a value 3 processor. This current has excellent coagulation properties, and it is very fast for the dissection of the submucosal space. However, it has a disadvantage, and this disadvantage is the creation of smoke, and the lens becomes very dirty quite soon, and you need to clean it from time to time. That's why I alternate this current with forced coagulation effect 3 from time to time. You see injection with the knife, so the needle is rarely used during this part of the procedure, except if there is fibrosis or not much submucosal tissue. The muscle is located at the right side, and the submucosal space at the middle, and the mucosa at the left side. So we try to work close to the muscle. And the purpose is to reach the other end of the tunnel in the area of the oral incision. Due to the size of the lesion, this patient has received general anesthesia in order to be calm, not painful, and not move. But some authors prefer simple sedation. So if I estimate that the procedure will last 1 hour, I use just propofol sedation. But this procedure, which lasted about 3 hours, I used general anesthesia. So here we reach the oral side of our dissection plane. This looks like a perforation, but actually this is the end of our pocket, and that's why it's very crucial to have done the oral incision before. So at this part of the procedure we have done a central pocket, and we have several options now. We can do a new tunnel at the right side, a new tunnel at the left side. I like a lot to use a clip and band traction to accelerate the procedure. So a clip and band is placed towards the right side now, and this will help me have a nice dissection field, because when you have a huge lesion, it is not easy to have a good orientation, and the lesion falls, the flap of the lesion falls over your field, and it becomes tricky to proceed. The clip and band traction is not always successful. Sometimes I have to try in several points, sometimes I have to detach an existing clip and band complex. So don't hesitate to change the position of the traction. Here we have a good dissection field. Now we have the muscle at 12 o'clock, the mucosa at 6 o'clock, and we dissect between. We try to have a thick submucosal space with enough blue, and we move only up-down, and we try to avoid using our right hand to turn the wheels. So we rotate the scope, the shaft of the scope, with the right hand, and we use up-down with the left hand. It's like driving. All this has to be automatic without a lot of thinking, but it comes with experience. Here we reach the end of our, not exactly tunnel, but our dissection plane at the right side. And although it looks like we have done a significant part of procedure, we have still work to do. We have to work now the left side, and for this part we will turn the position of the patient to the other side, and I will use a new complex of clip and band to have additional traction. Although we can continue like this, but you gain some time by having additional traction. Are there any disadvantages with traction? Yes. The traction can be very excessive, and it pulls the muscle, and you may provoke perforation, because while you dissect you have a lot of muscle fibers during dissection. So be careful not to perforate the muscle during this part of the procedure where you have a lot of traction. So here we reach the end of the dissection at the left side. So the procedure is almost done. Here you may question why I switched to another knife. I had some kind of dysfunction with last knife, and I had another knife available, and I used it. This was a dual knife. In order to recuperate, to retrieve this big specimen, I use an overtube, and the final step includes coagulation with a co-grasper of all visible vessels, very crucial, in soft coagulation mode 80 Watt. Here you see a huge vessel. I didn't show how I detached the specimen from the wall. I use an envelope cutter for this. So this is the final image. This was a 9 centimeter lesion, R0 resection, high-grade dysplasia, 1 night of hospital stay, and the patient had an excellent recovery. Thank you very much for watching.